When a patient comes into our clinic with recurrent or metastatic disease, we now have several options that we can begin to consider. The certainly traditional ones of cytotoxic chemotherapy, the more recent anti-EGFR therapy, cetuximab specifically, and now the anti-PD-1 antibodies, nivolumab or pembrolizumab. And there are many factors that can go into the decision of which one or combinations to use. For instance, if a patient is symptomatic from their disease and a response is important, that's a patient I would often consider treating with cytotoxic chemotherapy, usually doublet or the extreme regimen that adds cetuximab. We know that the response rates, especially for the extreme regimen, are going to be above 30%, maybe close to 40%. And in a patient who's having symptoms from their disease, a response to that individual is going to be meaningful. On the other hand, patients who I think may not tolerate cytotoxic chemotherapy, where a response is not necessarily the most important thing I want to achieve, and obviously survival comes into play, there's a patient where an anti-PD-1 antibody may be a better selection for them versus cytotoxic chemotherapy. And then the anti-EGFR agent, cetuximab, falls somewhere in the middle. Patients who, for instance, may not necessarily tolerate cytotoxic chemotherapy very well, perhaps have a relative contraindication to immunotherapy, that's where cetuximab, I think, plays an important role, an agent that's clearly active, clearly has efficacy, approved for these patients, and can be well tolerated as a single agent.
There are two major ways that we manage patients differently on immunotherapy as compared to chemotherapy with or without targeted therapy. One is toxicity management. The toxicities that we see on immunotherapy are radically different than those seen with chemotherapy with or without the addition of the targeted agent. In the case of head and neck cancer, really just cetuximab. Not necessarily worse. If anything, I would say in my practice, I fear nivolumab and pembrolizumab less than I fear chemotherapy, but it's just different, and it's important for the practitioner to recognize these differences and treat them differently. In particular, it is very important with the autoimmune side effects to recognize them early and act aggressively. And when that's done, patients can recover nicely from these adverse events and even go back on drug and benefit. The second major difference is evaluating progression or absence of progression. It's much, much harder with immunotherapy as compared to chemotherapy with or without targeted agents. With chemotherapy, and what I mean cytotoxic chemotherapy with or without cetuximab, you pretty much know where you stand. The cancer is shrinking, it is growing, or it is the same. With immunotherapy, we see all kinds of patterns of response. In particular, when there is apparent early progression, we don't always know if that is going to be real, what's going to happen on the next scan. And so what I do with this in my practice is that for the average patient with progression on an immunotherapy drug who is symptomatic from that progression, for the most part, I stop and switch them to something else. The phenomenon of pseudoprogression, where you see clear apparent growth of tumor followed by dramatic response that we learned about from the melanoma experience, does happen in head and neck, but it's far, far, far rarer. In contrast, if I have a patient who's not terribly symptomatic from their apparent progression, in particular the patient who says that they feel much better with their progression, the cancer not pressing on a major airway, not pressing on a major blood vessel, not causing major pain or other symptoms, I'll go another scan to see what happens.
When we think about immunotherapy, what I think really gets us excited is not only the fact that patients are responding, and if you think about it, if you step back a moment, what we're talking about is interrupting a single receptor ligand system in the immune system, and we are seeing responses across multiple tumor types. It speaks to the importance of the PD-1, PD-L1 synapse, but it also is incredible to think that if we can just manipulate the immune system ever so slightly in a cohort of patients, we can begin to see sometimes very dramatic responses. Going on from there, what is exciting from a clinical perspective is that these responses can be deep, they can be complete responses, and they can be durable. As the data mature and as our clinical practices and clinical experiences with these agents mature, we're beginning to realize that there are some patients who can have responses that last not only several months, but we're now getting into a few years of patients who had recurrent or metastatic disease who achieved a complete response or near complete response, and the disease has yet to progress or return. That's pretty incredible and, in my mind, unprecedented in our therapy for these patients.